Over to Dr. Sachin. So, as a senior consultant, Sachin Mathew Kochi, mainly talking about specular microscopy. Of course, various things for retroplasty and all these things. So, Dr. Sachin.
Thank you. I mean, at the onset, I will thank Dr. Kala again for involving me in this session actually. Okay. Right. So we are actually talking about this pre-op assessments actually, and this is actually very important, again, an important tool in most of the anterior segment surgeries. Specular has been around before also, but nowadays the significance of that thing is extremely important in the pre-op assessment of anterior segment surgeries, both in cataract and keratoplasty. So, I'll be talking about the fundamentals and then corneal endothelial assessment and the clinical applications. Coming to the fundamentals of specular, the specular is a diagnostic modality of imaging the corneal endothelium that allows for the direct observation of the endothelial cell morphological characters either in a clinic or an advanced setting. This is the usual, common horizontal upright specular what you see in the clinics. It's routinely used in the assessment of endothelial health in various endothelial diseases, evaluation of the cornea prior to the cataract surgery or keratoplasty, or as a follow-up of keratoplasty. Now the principle is pretty simple actually. The light striking on a surface is usually either reflected, transmitted or absorbed. And some of the light which is reflected specularly, that is important. It's called mirror length, and where the angle of reflection and the angle of incidence is the same. So when the light actually passes through the cornea, it encounters a series of interfaces between the optically distinct regions. Now the endothelial cells, why it is important is because it has a refractive index greater than the 1.336 which is seen in the aquazoom. So because of this interface, it can be imaged because the endothelial cell aqueous interface reflects around 0.022% of the projected light. This is absorbed in the camera monitor and we are seeing the endothelial image. Most of the specular microscopes are designed from the original microscope introduced by Maurice for the laboratory use. This is what is happening from the light source. It falls on the cornea, and there's exact specular reflection which is absorbed by a camera monitor, and then we are seeing it. Types, usually, as I said, there is a horizontal one which we usually see in the clinics, and an upright one which is used in the eye bags. The presently available instruments for use in the clinics are either contact or non-contact. The contact one will be applanating the corneal surface, so the image will be bigger. And the non-contact modules, which uses an automated image focusing technology, so the image will be a little smaller. Now coming to the corneal endothelial assessment, we should have an idea about the morphology of the corneal endothelial cells. This is the normal morphology. You can see that it's endothelium, as you know, it's an anatomical structure responsible for maintaining the transparency. So anything which alters the cell size or shape may indicate cellular stress and pathology in the cornea. So it's got a characteristic hexagonal shape, and it's a tightly packed mosaic, and this pattern should be imprinted in you before actually you check the specular. This is a normal specular. You can see that the corneal endothelial cell density declines through the age. This one is a 12-year-old and this one is a 40-year-old. You can actually clearly see the difference. Even in the cell density, 3546, 2444. The average area you can see it's 282 and here it is 409. So the cells become bigger in size, the cells become less in number. So the corneal endothelial cell density declines through the age, through life at an average rate of 0.6, and at birth the human endothelial cell density is around 5,000, 6,000, and by the time it comes to the adulthood it will be around 2,500. Right, now these are the parameters usually we study and we look at the specula. If you don't, physically you can look at the cells like that, but look at the parameter. This is the usual picture you see in the specula what we get. We have to look at the number of cells which is studied, CD which is called the cell density. This is the average area, standard deviation. This is coefficient of variation, which is a study of the polymechanism, and then the CCT. These are the things. CCT is the central corneal thickness. So, you can see that here the cell density is 2298, which is good. Average area is also reasonably okay. Coefficient of variation, which is I will come to that later, and CCT. So these are the things which we usually look at. These are the parameters we study in the spectrum. Now techniques, there are different techniques. I'm not going into detail about that. There is a frame method where the counting of the number of cells is in a frame. There is an error in that because some of the border cells will be missed out. So we have a variable frame method. Then there is a center-to-center method and a comparison method. And most of the time we take an automatic assessment, but sometimes if it is the clinically the interface is not very clear, we can go for manual counting like this to get a better picture. Now these are the abnormalities. As I said, the polymeganism, it is actually the first sign of endothelial cell disease. I mean, CV values 32 to 40. I mean, if it is more than 40, it's abnormal. So look at the hexagonal shape and the area of the cell. So if it is more, then that is for the first sign of endothelial cell disease. Pleomorphism refers to the variation in the cell shape. I mean, less than more than 50% if the hexagonal shape is not maintained, it's abnormal. Now, some of the clinical applications in ophthalmology. Now, we all know that mostly we use the specular for the diffuse endothelial corneal dystrophy. I mean, it's very commonly picked up. The data is the one which is classically, they are the formation of decimate membrane excrescences. That they are the focal thickening and projections in the otherwise homogeneous decimate membrane. And you can see that is a stage 3 data and a stage 2 data. What happens in data, it is like it causes dropout areas in endothelial image. And FECD usually begins with the changes in the central cornea and then goes to the periphery. Now what I'm trying to say is it's pretty obvious that in FECD you will see a data, but whether we should take it as the final say in planning the surgery or anything, that is, say here we have a specular microscope or a non-confluent data, but if you look at it, the cell pattern is normal. And so the cell density is 2372. Even if the data is there, the cell density is good. But if you look at the average area, it's 422. And when it comes to this picture, if this is again a non-confluent data, you will see the data, but the cell density is less. So just by looking at the data, you cannot make out the assessment of the condition. Here the cornea, the stroma is still clear. And in this one, if you look at it, this is a confluent data. Because it is in the center, you're not getting a good picture. You cannot make out the cell size or shape or anything. But if you look at the CCT, it's still 448, so it's still actually good. So just by looking at the specular, you cannot make the diagnosis or prognosis of the condition. Here you can see that the central, there is a confluent data, and the center part, you're not getting the picture at all. But if you just put it to the side, the periphery, you can get a almost clear picture. I mean, you can see the data, but you look at the parameters, it's around 3,000, 2,000 something, and the thickness is less. So the specular microscopy imaging in FECD should be correlated to the nature of the clinical condition. That is what I was trying to say. Just by looking at the specular, you cannot make the assessment. And fuchs and cataract, that is a usual problem. The decision making of the cataract surgery in early stages of FECD, it's mainly based on the patient's clinical symptoms like early morning blurring, pachymetry, and features of subepithelial changes. And this was identified based, this is it's just American Journal, it's just got published in 2025. Lots of cornea specialists all over India, all over the world, they came to a consensus as to how to go about, if you have a corneal FECD, how to go about deciding on the corneal intervention. This is actually good. But mainly I would say it's like, you should go by your clinical specular correlation. I mean, it should not be like completely based on the specular. Some of the other conditions like Eyes syndrome, here you can see that the rounding of the cell borders, you can see the two PAs and a little bit of haze here in the cornea, and you can see the rounding of the cell borders and increased intracellular blackout area. You can see a reversal of pattern here, because usually you see a black border and the center is white. It will be just reversed here. When the endothelial cell borders is seen as in the white instead of black, and instead of the cell seen as black instead of white. So that is the classical eye syndrome finding. The other secondary corneal endothelial disorders, cataract surgery and keratoplasty usually see endothelial change, pseudoexfoliation. Systemic conditions like a CKD patients on dialysis, I mean, these are the conditions you should be always thinking about before going into the surgery. I mean, you can, if you have a chronic kidney disease patient which is on dialysis, you should always do the specular and look out for that. Medications like anti-Parkinson's and drug like amantadine, In forceps injury like this, you can see early endothelial change, macular corneal dystrophy, uveitis, endothelitis, and in just contact lens wear, which causes a CL-induced hypoxia, can cause an endothelial damage. These are some of the pictures. You can see a therapeutic penetrating keratoplast which is done on the right side. Left side it's normal. You can see that the cell area, that is the main thing you should look for. Look at the cells here. I mean, here the cell area is 362, but here when you look at it, it's 801. So the cell area is increased. That is the polymerism. And cell density, if you look at it, 2764 and 1248. So that is the cell density loss. And this is a penetrating keratoplasty which was done 30 years ago, and you can see the difference. Even if it is clear, if you look at the counts, it is actually different in three. This one is only 888, 731, and 1144. So even if it is normal, this is actually a guide for the prognosis of the disease. And in this picture, you can see a post-DSEC case. I mean, this one is like the counts are pretty good. But if you look at this is the count 1020, and the area is actually 980. So there is an early polymycotism, which is a sign of an impending failure which is going to happen. This is a macular corneal dystrophy, which DALC was done, but the DALC is clear. But if you look at the specular, you can see an endothelial damage which is happening. And these are the uveitis. I mean, in a uveitis, actually, you can see that there's a change in the early polymycotism here. And the forceps injury, again, you can see a polymycotism here with the cell count. These are important when you're planning a cataract surgery in these cases. And the eye bag, as I said, it's an upright specular, and this is what usually they'll be sending in you with the tissue along with that. This is from LF actually. So this is a specular which is done, and then they'll be like telling which is suitable for PK, LK, or therapeutic. And a wide field XY or dual imaging specular microscope is used like a cell check. Donor corneas must be warm to 25%, as I said. The donor cornea is suitable for penetrating keratoplasty, which is like more than 2000, and EK, which is 2200 usually. Role in research, I mean, it enables detailed study of corneal cells, enhancing knowledge of corneal structure and function, and this is something which we have to look for. Because it is still an expensive machine, and you can't carry it around in a community-based or a pediatric cases like in a ECA, in a UA condition. You can't take the specular and take in a check case or something. So smartphone-based endothelial imaging is something which is evolving. And in conclusion, I mean, this is the one thing which we can take home from this talk, because it should be a clinico-specular correlation in pre-op diagnosis. It should not be just a specular, it should be a clinical and specular imaging. Right, thank you.
Thank you, Sachin, for elaborating. One question. Regarding the importance of specular microscopy, especially with clinical correlation.